Well, in our current state of practice, neonatologists are forced to function utilizing a symptom-based approach. Let me explain it a little more. When we are faced with a critically ill patient that is deteriorating at the bedside, we evaluate the symptoms, including poor perfusion, blood pressure values, oxygenation status, metabolic status, etc., which are measurements that essentially can tell you that something is wrong, but they can't tell you what it is that is wrong. We're somewhat trained to respond to these symptoms with the listed interventions. So for example, let's take hypotension. It's not uncommon for clinicians to first give a fluid bolus, then start some medication such as dopamine. If that's not working, hey, let's crank it all the way up and or maybe add something else. So dobutamine, epinephrine, maybe some hydrocortisone, depending on their institutional protocols. The main problem with this approach is that there's a lack of precision. Without understanding the actual physiology, it's really difficult to determine whether the hemodynamic instability is the result of a PDA. Is it pulmonary hypertension? Is it heart dysfunction? Is it something else? And we also don't know what the effect on organ perfusion is. Any of these physiologies could give the nonspecific symptoms listed on this slide, though we may not necessarily think of PDA, for example, when we have an oxygenation problem. Having real-time physiologic data provides the ability for us to deliver more focused and targeted cardiovascular care to this population.